Thank you very much to the organizers as well as the Ministry of Health and Wellness in Kingston, Jamaica for allowing me to present on the case study of Kingston, Jamaica for the Fast Track Cities Initiative. My name is Dr. Jeffrey Barrow, and I'm a member of the steering committee for the FTC in Kingston, Jamaica. So an overview of Kingston and in Jamaica. This picture shows you the downtown Kingston area, which is a major corporate sector for Kingston. On the left, you can see in the distance the Kingston Harbor, and on the right, the beautiful Blue Mountains of Jamaica. Next slide. So a lot of this presentation, you'll hear us bring together Kingston and St. Andrew, and the reason for that is that in the early 1920s, there was an amalgamation of the local government bodies to form the Kingston and St. Andrew Corporation, and this is the organization with which the initiative is directly interacting with. Later on in the 1990s, there was a healthcare reform which decentralized healthcare to the regional health authorities from the central ministry. So the total St. Andrew area is around 430 square kilometers, and the Kingston area is 22 square kilometers. The total population is about 820,000 people. So Kingston has the most densely populated area of 11,500 persons per square kilometer, which equates to around 4,500 per square mile. Next slide. So looking at the overall morbidity and mortality for the country of Jamaica, you can see on the left-hand side that the data from 2008 shows that 18% of deaths were caused by cerebrovascular, 11 by diabetes mellitus, 10 for ischemic heart disease, and at number 6 you can see HIV/AIDS, which represented 4% of deaths. However, you can also notice that it has quite a large percentage for the years of life lost for the population. On the right-hand side, you can see the population density for HIV cases, and on the bottom right-hand side is the Kingston and St. Andrew area, which shows that it is the highest along with the St. James Parish for population density of people living with HIV. That's data from 2017. Next slide. So an update on the Fast Track Cities Initiative in Kingston. Next slide. So we really have focused on objectives 1 and 2 for the FTC, whereby we are looking at the optimization of service delivery, looking at developing a comprehensive city implementation plan, and creating an enabling environment for the implementation of that plan. Objective 2 is really looking at the utilization of data. So we have created an active online web portal, which is in development, and I'll show you a couple of screenshots of that later. And then also, we want to conduct a quality of care analysis for people living with HIV who access care in the Kingston and St. Andrew geographic region. Next slide. So here we look at the first objective. On the left-hand side, it shows the HIV Care Continuum as of 2019. The red lines on the bar chart indicate the 1990 targets. So the Kingston and St. Andrew is estimated to have a total population of 9,861 persons living with HIV. Of these, around 95% have been diagnosed with HIV. And this represents approximately 1/3 of all the HIV diagnosed persons living in Jamaica. And that equates to an estimated HIV prevalence in the Kingston and St. Andrew region of approximately 1.4%. So the continuum really shows that 93% have been diagnosed, 51% retained in care, 50% are accessing antiretroviral therapy, and 33% are virally suppressed. So in terms of the 1990 figures, that would equate to 93, 53, 66 for the KSA region. On the right-hand side, it really shows outbreak of an analysis looking at the activities for key populations reached between 2017 and 2018. And you can see that 91% of estimated men who have sex with men were reached with HIV prevention services, and that's a defined package of services which includes testing, education, and prevention through condoms and other risk reduction methods. The percentage of men who have received an HIV test was around 82%, and they also received the results. Looking at sex workers, you can see that around half, or 48%, were reached with the HIV prevention program, and then for testing, 46% of those sex workers received the test and got their results back. Looking at the transgender population, 14% were reached and with prevention programs, and 12% were tested and received their results. Next slide. So when we look at the sex, if there is a sex disparity, we look at females on the left and males on the right. And this is 2019 data, which comes from their EPI data, as well as the treatment database from the Ministry of Health and Wellness. You can see that the overall picture for both men and women appear to be reasonably similar, and we're not seeing a lot of differences in terms of outcomes, just looking from a sex breakdown. Next slide. However, when we start to look at age disparity, so on the left shows a cascade of care for adolescents aged 10 to 19 who are in care. So we can see that there was a total up to 2018 of 286 adolescents who had ever been linked to care. There's a pretty sharp drop-off rate, with 45% being retained in care, 35% on antiretroviral therapy, and 21% who are virally suppressed. You can see that there's quite a gap between this population and the total population cascade that I showed earlier. Next slide. So some of the critical components that were seen outlined in Objective 1 included promoting leadership. This is the launch of the pictures from the launch of the FDC in Kingston. And on the left-hand side, you can see senior members of PEPFAR, the Ministry of the Government of Jamaica, the Ministry of Health, the Kingston and St. Andrew Corporation, UNAIDS, as well as the Ministry of Health. On the right, it shows the strengthening of these critical partnerships with the signing of a memorandum of understanding around the FDC, which was signed by both the local government of KSA, the Ministry of Health, as well as the Government of Jamaica at large. Next slide. So here we see the use of the dashboard. So here are some screenshots of the dashboard as it exists today. And you can see on the left the HIV dashboard, which depicts the geographic locations for specific HIV services. Those include harm reduction services, testing locations, and non-governmental organizations that offer support to people living with HIV. On the right-hand side is a depiction of the COVID-19 dashboard, which at this time is showing you hospitals where you can receive care if you are experiencing symptoms of COVID-19. Each one is accompanied by a message from the mayor of the Kingston and St. Andrew region, indicating the political support at both the national and the local level. Next slide. So looking at the programmatic achievements so far of the collaborative, there has been a lot of work done with the shelter health program, which was seen as an opportunity to improve the quality of life for homeless in the Kingston and St. Andrew region, which is a key target area for the municipality. We also know that it is an important area for HIV prevention, where we have 14% prevalence in previous studies in the HIV population. So we have formed partnerships with the local focal points within local government for homelessness. as well as buy-in from the shelter health programs from both the government and private sector facilities. In addition, along with our international partners, so Global Fund is funding the PrEP implementation project, which is ongoing. The phase 1 project is ongoing at the moment, where we're looking at heterosexuals as well as men who have sex with men, utilizing PrEP to decrease HIV transmission. There's also HIV public-private partnership, where the service expansion for access to HIV-specific care, both the clinician, pharmacy, and laboratory locations are being expanded. Next slide. So just a little bit about the COVID-19 epidemic in Jamaica. Next slide. So looking at the activities, so the Emergency Operations Center was activated in Jamaica on January 30th, 2020, followed by the establishment of a task force specifically around COVID-19 and HIV in February 2020. And that included an early involvement of the regional health authorities, civil society, and international partners. So our first case was diagnosed in March 10th, 2020. As of June 23rd, we have 670 cases, of which 164 were imported cases. And we have about a 77% recovery rate, with an age range of affected persons between 2 months to 87 years old. And we have had approximately 10 deaths. So in terms of the impact on the Fast Track Cities initiative, it really has meant quite a few delays in the activities based on the restrictions placed on movement by the government of Jamaica. So we have delays in the site assessment of the homeless shelters, delays in the commencement of the quality of care analysis, and delays in our HIV sensitization training of the local councillors for the local government of KSA. So the Ministry of Health response, as I mentioned, they created a task force for COVID-19 and HIV. And what this involved really was the operationalization of task shifting for modalities for interventions. A lot of it has moved to online, as well as phone call, telephone interventions. So risk reduction counseling is no longer done in person. That's done over the phone. A lot of the contact investigation activities are also moving to the telephone interventions, as well as expansion of access to condoms and lubrication to several additional outposts. Multi-month dispensing, reducing times of waiting in the pharmacies, as well as access to care in the health clinics has also been done. There's a redesigning of prevention messaging for prevention at home rather than, which is a new intervention. We have an increased focus at the treatment sites for evaluation of gender-based violence. And of course, PPP and social distancing are enforced at each of the clinic visits. We've also seen a shifting of the contact investigators away from HIV to focus mainly on COVID contact tracing.
Good morning. We are going to talk a few minutes on the HIV epidemic in Salvador, Brazil in times of COVID and the potential impact of the pandemic on HIV care. Salvador is one of the largest Brazilian cities, about 3 million inhabitants. It's the capital state of Bahia and in northeastern region of Brazil. Salvador is also one of the Brazilian cities with the highest HIV incidence. It was estimated about 5 per 1,000 patients in 2018. And below here, you can see the curve over time from 2007 and 2015 in terms of incidence rate per 100,000 patients. The response of the city to HIV epidemic was similar for the rest of the country. We have diagnosis tests, rapid and conventional. They are widely offered at basic health unit free of cost. We also have our network of 6 referral centers. Once a patient is diagnosed with HIV, He is referred to the nearest referral center. We have 6 in the city. And HIV staging is performed by measurement of plasma viral load, CD4 count, and also performing serological tests for common infections like hepatitis B and C, CMV, BV, and syphilis. In addition, a clinical investigation is performed to detect any comorbidity and opportunist condition. ART starts regardless CD4 count as soon as possible, and ART also is available at a low cost. A prescription for antiretroviral therapy is valid for 6 months. Patient has to come periodically to receive to take the medicine at the pharmacy at the centers, and ART is dispensed at intervals of 1 to 3 months, depends on the viability of a specific regimen. Every 6 months, they are asked to provide a recent plasma viral load test at pharmacy for checking treatment effectiveness. PrEP and PrEP are just also available, although PrEP is currently limited to the largest center in Salvador. And they also distribute free condoms, male and female condoms for the patients. If a patient presents a virological failure while on antiretroviral therapy, he is sent for genotyping free of cost. Some points of the policy overview for HIV in Salvador. HIV testing is widely available, but many at-risk populations are not routinely tested because stigma, discrimination, or any other barrier to access healthcare units. The referral centers in Salvador for HIV care are usually at the limit to attend new patients, so only half of them are receiving new patients for follow-up. And we have still a need, most of the case, patient has to come monthly to the referral center for refill for specific antiretroviral drugs because some regimens are not available for dispensing for longer period of time. And we also need more social support for patients because sometimes they don't have even the money to pay for transportation to come to medical visits or to take the medicine. And this can affect the adherence to therapy. The first cascade of care of Salvador in 2014 showed a clear gap in the first 2 nights. The rate of patient diagnosed was only 2/3. For the estimate 12,000 patients, only about 8,000 were diagnosed. Most of them linked to care, less retained in the service, and half of them received antiretroviral therapy and reaching viral load suppression. It's important to note that viral suppression for Brazilian government is a viral load below 1,000 copies, not undetectable like 50 copies we use in clinical care. So this is a summary of the targets of 1999 strategy, and in terms of diagnosis, linkage to therapy, to a center and starting antiretroviral therapy and viral suppression. 1 year later, we noted some slight improvement. The percent of patient diagnosis increased to 69%, 61% were linked in receiving antiretroviral therapy, and 9% of them were presenting viral suppression. And here we can see the rough number for the total of patients estimated infected patients in Salvador and the cascade of care until viral suppression. Our current view shows that the picture is a bit different. We have about 20,000 patients, estimated infected patients. 13,000 of them were diagnosed, 63% linked to a referral center, and 54% retained to care and receiving ART, and all patients on ART were considered reaching viral suppression. It means that we have 100% of patients on therapy presenting viral load below 1,000 copies, 80% of the diagnosed were on ART, and 95% were linked to care, considering only those that were diagnosed. So the remaining gaps point some needs for improvement in diagnosis. We have still a 44%, not 24% of patients still not diagnosed. 10% of them, of those diagnosed, not receiving NAT. And we have very good results in terms of viral suppression, 100% on therapy at viral load below 1,000 copies and 93% below 50 copies per ml. What about the impact of COVID-19 in Salvador care for HIV patients? We have the first case diagnosed in March 13, and all initial cases were from patients that have visited European countries at that time facing a peak in COVID-19, like France, Spain, and Italy. By June 21st, we had about 50,000 cases diagnosed in Bahia, half of them in Salvador, and 3% of them were dead. In a red dotted line, we see the expected curve of the pandemic in Salvador, and then the green bars, we can see the real numbers. And we can observe that in the last few weeks, there is a trend for flattening the curve. And from the last 2 weeks, there is a stabilization in the numbers of COVID in our states, especially in Salvador. How COVID affected HIV care? It's clear that the impact could be substantial. Most referral centers stopped routine of care and do not attend patients scheduled. All prescription had to be extended for the validity for 2 months for patients considered stable, undetectable viral load and no comorbidity. Most of the medical visits had to be postponed, and pharmacy become to deliver a refill of antiretroviral drugs for longer than before to avoid the need of visits to referral centers. And at the centers, only patients present with detectable viral load or any acute complaints are attended on a regular basis. So in the current situation, we have only half of patients coming to scheduled medical visit because they are afraid of contamination in the hospital setting. They have some restriction because the specific lockdowns in some areas of the city. And we have, for this population, strong concerns on adherence to therapy and maybe some problems with comorbidity once they are not being followed on a regular basis. There is no data on the specific impact of COVID-19 on HIV patients, and we have an urgent need of planning the return to normal situation because this patient cannot stay without continuous medical care. Some of our very urgent needs are clear. We have to adequate our facility to avoid crowded waiting room and to avoid cross-contamination from coronavirus between patients attending scheduled visits. We are trying to increase the use of telemedicine to care and manage patients considered stable with no comorbidity. And to estimate the impact of coronavirus infection on HIV population, we are performing serosurveillance to see the seroprevalence in this specific population. I believe these are the main challenge for the next few weeks we have to face. Thank you very much.
My name is Carlos Del Rio, and I'm professor of medicine at MU University School of Medicine. And I'm here invited to speak on where we are in Atlanta in achieving our 90-90-90 targets. I want to thank the organizers for inviting me today to speak on this topic. So Atlanta currently has a prevalence of people living with diagnosed HIV of approximately 36,000 individuals, of which 80% are men, 70% are Black, African American, 7.6% are Hispanic or Latino, and 16.8% are white. In 2017, a total of 1,344 individuals were diagnosed with HIV, of which about 77% were men, 82% men who have sex with men, and 71% were Black. And the mortality from HIV/AIDS in Atlanta in 2017, 347 people died. And in the state of Georgia, 772. So it's close to half of the deaths were in the city of Atlanta. So why are we concerned about HIV in this area of the country? Well, because if you can see from this map of new diagnoses in 2017, there were approximately 38,640 new diagnoses with HIV. In Georgia, with a rate of 30 per 100,000, is actually one of the most impacted states. Similarly, with 602.4 per 100,000 population, we also are one of the states with the highest number of persons living with HIV per 100,000 population. Similarly, as you can see from the slide, HIV/AIDS continues to be one of the leading causes of death for individuals between the ages of 20 and 45 years old. And this has been something that has continued to demonstrate people who are not in care, particularly African Americans, who are not in care and who are therefore still dying of HIV. So what has happened over the last decade or so with HIV? Well, we really haven't seen much of a movement. The number of men and women diagnosed and the number of total people diagnosed with HIV has essentially stayed flat, maybe a little bit of a decrease in women, but not much. And in fact, when you think about it by jurisdiction, you think about Fulton County having a rate of 67.8 per 100,000 population and new diagnosis. Compare that to New York with 29.2 or San Francisco with 25.6 per 100,000 population, and you realize why this is an issue. We, in addition, think that there are about 3,000 people in Fulton County who have HIV but don't know it, and therefore undiagnosed HIV continues to be a significant issue. And of those, probably about close to 20% of persons living with HIV in Fulton County are not aware of their HIV status, and that a significant percent of them are men who have sex with men. So what has been the response of Atlanta up to now? Well, we'll start by saying that the city of Atlanta does not have a health department. The health department in Georgia is responsible for all the counties, and Georgia has 159 counties, which is second only to Texas, who has 254 counties, and therefore care is very fragmented. The city of Atlanta itself, the Atlanta MSA, has over 20 counties. One of the biggest counties is Fulton County. As a result of this concern, in December 2014, the Fulton County Board of Commissioners created the Fulton County Task Force on HIV/AIDS, and the mission was to end AIDS in Fulton County and to create a strategy. And the leadership included people living with HIV as well as national experts. And you can see here many of those national experts, Dr. Wendy Armstrong, Dazon Diallo, Dr. Jonathan Colasanti, and Daniel Driffin. And the participation was by 14 commissioned appointed members and 25 non-appointed members. And there were unlimited members who were committee members and many ex-official members from Fulton County. And of course, a driving force of all this was Dr. Melanie Thompson, who really has been the engine behind a lot of efforts to end AIDS in Fulton County. The structure of this committee was divided into committees focusing on social determinants of health, on prevention and care, on data, and on policy. And a lot of the methodology was around seeking a broad input from the community, involving people living with HIV, and creating, through community engagement, a lot of evidence-based decision-making of what needed to be done to address the epidemic in this city. As a result of these meetings and many other things, a three-phase approach was done. The first was a phase one, which was initial document. The second was an action plan with achievable objectives. And the third one was a prioritization of the transition to a permanent advisory committee. I think learning and how to do this, we learned several things. Number one is that we had 10 key priorities. Stigma kills, and we would not tolerate it. We wanted to make care and services client-centered. We wanted to make it easy to get into care fast and stay in care and remain healthy. We wanted everyone to be tested for HIV. We believe that HIV is preventable, so we could prevent it. We did not want any more babies born with HIV. We wanted to educate in HIV prevention. And we believe that housing is HIV prevention and treatment, that mental health and substance abuse treatment are important, and it was necessary to create policies that promote health. So I want to then mention that in collaboration with IAPAC, a dashboard was created, and the dashboard is now available on the web, that has a lot of the targets of where is Fulton County in achieving the 90-90 targets and in the HIV care continuum. And as of today, we have 84% of individuals living with HIV diagnosed, 87% of those diagnosed on antiretroviral therapy, and 82% of those on antiretroviral therapy are virologically suppressed. We are, though, having some difficulty in retaining people in care. And in fact, retention in care is a major issue for us, which with only 50% of individuals living with HIV being retained in care, and a lot of the efforts are being put in that arena. So then comes COVID, and COVID hits the city in a significant way, and we're still being impacted by COVID. And as a result of COVID, we have created, first of all, with the city of Atlanta, a COVID dashboard that you can find Atlanta Strong. And you can see where we are here in new COVID cases, COVID hospitalizations, etc. But we have been significantly impacted. And in fact, clinics have transitioned very rapidly to telehealth. Clients have been given 3-month supply of medications. And every effort has been done to maintain having clients engage in care and on antiretroviral therapy. But without doubt, HIV testing has gone down, STD testing has gone down, PrEP clinics have not been as active, and I'm concerned that HIV will then rebound and take an increase in number of cases as a result of COVID. So in conclusion, AIDS is far from over. Atlanta is one of the epicenters of the current HIV epidemic in the US. I think the Fulton County strategy is good, but still needs to be implemented. Community support has been critical, and the impact of COVID-19 is likely going to be significant. And I want to conclude by saying that the key ingredients to any strategy to end an epidemic, including COVID or HIV, are political will, strong leadership, working groups and defined goals, and community engagement and communication. And with that, I'll end, and I want to thank the organizers for inviting me and my presentation. Thank you very much.